So I think we've listened with interest. Just let me shout out if you can't hear us. I think we're going to take you on a journey to the future, actually, from what we've been hearing. And we're going to give you the UK lung cancer screening experience and the last talk with interest. We haven't called our program in the UK. Oh, sorry, can you hear me?
Sam.
I can hear an echo, Tim.
Continue.
Okay, so our program is called the Targeted Lung Health Check, and straight away I think that offers some reduction of the stigma associated around lung cancer screening. So we know about all the trials, the NLST trial, the Nelson trial. The science of lung cancer screening is proven. I've worked in lung cancer now for over a decade, and to me, it's pretty simple. We diagnose lung cancer too late. We need to diagnose it earlier, and we know lung cancer screening saves lives. So as Dr. Berger quite nicely put it, something's blocking us in terms of getting to where we need to get to, and the analogy of build it and they will come. We're going to take you through that journey, because that's effectively what's happening in the UK, because we've moved beyond just doing trials and then doing another trial and then doing another trial. We've actually gone to a real life program, which is actually screening patients and saving lives. You know, where from our perception, where is the US and most of Europe? Well, we know lung cancer is the third most common cancer, but it's the biggest cancer killer. And actually, in my 10 years of working in lung cancer, that's a statistic that we have to roll out every single year. And I always ask myself the question, well, when are we actually going to do something about it, rather than just roll out the same stat? And this is what this is about. This is about doing something different and actually improving lung cancer outcomes, particularly for patients for whom lots of new treatments are available. So it's not just about thoracic surgery anymore. It's about stereotactic ablative radiotherapy. It's about radiofrequency ablation. It's about gene-targeted tablet therapies for mutations. So there's lots of treatments out there. So we need to move our diagnosis and stage shift to stage 1 and 2 diagnosis. We've shown through the trials that we can decrease lung cancer-specific mortality. We've got guidelines, and these are the USPSTF guidelines, which are recently changed in 2021 to allow screening of slightly younger cohorts, so starting at the age of 50 instead of 55, and actually reducing the amount of cigarettes that have been smoked from 30 to 20. And we can debate that forever, but quite nicely in one of the presentations this morning, it's clear that, you know, a lot of lung cancers also occur in non-smokers. So, you know, up to 25% of lung cancers, usually adenocarcinoma, can occur in non-smokers as well. So there's a long ways to go before we make a difference, but we need to start that journey now. And this is where the UK's got to. And despite all these trials, I think from our reading, the uptake rates across the US currently between 4 and 6% or less than 6%. So that's pretty low. We know, you know, in medical school and reading other things, we know the principles of screening, the 10 parameters of screening, and I would advocate that lung cancer screening matches all of them. It's an important health problem. Is there a test that can potentially help diagnose it? Does it save money? Does it save you spending lots of money on expensive chemotherapy, radiotherapy, and medications and stage 4 disease? Yes, it does, but we still have barriers as to why we're not doing this. And some of those are fundamentally related to the fact that, you know, patient awareness. So there's lots of awareness out there of breast cancer screening, but less so about lung cancer screening. The socioeconomic groups that, you know, potentially you target with lung cancer screening, deprived areas, the stigma around lung cancer screening. So those are logistical issues, but there are also clinical issues and barriers. So which patients are we going to select? What about the false positives? Well, what about how are we going to introduce smoking cessation as part of just scanning people? How are we going to deal with incidental findings? And what about radiation dose? The UK position is that between 2011 and 2013, they looked at mortality data over time, collected until 2020, over sort of between 7 to 9 years, and they showed that there was a 16% reduction in lung cancer mortality. And in a nutshell, if you look at these 4 graphs, they show clear divergence between the control arm and the screening arm. So screening works and screening saves lives. We know that. But how do you jump to the next step and actually start screening? Because I think, lots of countries do a repeat trial, as I've already mentioned. This huge trial happened in the UK. So this was in London, 25,000 patients run out of University College London Hospital using BTS nodule guidance or British Thoracic Society nodule interval guidance. And it was in the press, 70% of lung cancers were caught at an early stage, and that gained momentum. And this trial will become the screening program for this patch of London. So they're just rolling into a program rather than just doing a trial and stopping and then and deciding what to do next. And that's how it's been working. There's various risk models out there on who gets a scan. There's the LLP model, the Liverpool model, there's the prostate, lung, and colorectal model. And essentially, depending on which model you choose, they target patients with between a 1.5 or 2.5% or higher risk of getting lung cancer diagnosed on CT. But actually, the way we run our program is we invite patients. So we don't have insurance in the UK. We have a National Health Service, free at the point of delivery for all patients. And the program works closely with primary care and family physicians to send out invitation letters to invite people between the ages of 55 and 74 who have ever smoked, so our target audience is ever smoked, to come and have an assessment, a lung health check, to determine if they warrant a CT scan. And when you invite people, they will come. And so we have a targeted lung health check program in England, which is running, and it started in 2020. And it started as small pilots around the most deprived regions or areas of our country. Not as big a country as yours, but we have, lots of patients, lots of smokers, lots of lung cancer. It's centrally funded from government. As I said, it's for ever smokers. We use low-dose CT, and currently we are doing 2-year intervals, so 24-month cycles. But lots of work is going on, and we're gaining data from a real-life program to determine what is the utility and value. Do you save more money by doing annual scans, or do we stick to a 24-month cycle? But this is all ongoing, and we're learning as we go, and that's been the principle of our program. Importantly, crucially, in 2020, the UK government, or the UK National Screening Committee, had said screening is not currently recommended for lung cancer based on all the data. But in 2023, so this year, a landmark decision was made where evidence from the targeted lung health check program was looked at, and the UK National Screening Committee said, actually, now screening is recommended for this condition. And not only was it recommended in England, it was recommended for the devolved nations, so Wales, Ireland, Scotland, etc. So what they've effectively said is that there should be a national lung cancer screening program in this country. We're already scanning between, I would say, 100 to 200,000 patients a year as part of the national targeted lung health check program, and this is expanding. And what's happening is we are in this phase of the red circle. We're in phase 3, where we're doing a phased rollout and gradually increasing the amount of patients we're scanning by uncapping our eligible population of who's eligible for a scan, with the aim that by 2026, that will just morph and seamlessly transition into a rolling lung cancer screening program. Uptake rates are between 50%, some sites report 70%, and that's a lot of what Rob touched on in terms of engaging with the community, advertising campaigns, sponsorship from charities such as the Roy Castle Lung Cancer Foundation. And the estimate and the figures show that we will be doing, hopefully by 2026, the NHS is usually slow at getting things off the ground sometimes, we'll be doing a steady state of 1.2 million CT scans a year. Now that's a lot of scans, and there's a ways to go before we get to that volume. So we need to start building for that now, and that's what's been happening. What are the potential failure points in this journey? Well, we all know about staffing. Big burden in radiology, how are we going to do our staff? But actually it's the administrative staff, the staff on the ground that send the letters, that book the appointments. Without that key cog in the wheel, you don't have a lung cancer screening program. You can have as many surgeons and radiologists in the world, but without that front end, you can't do screening. Respiratory physicians. Then there's the hardware and the IT. How are we going to acquire these scans? Is that going to be on mobile vans? Is that going to be in hospitals? Is that going to be at bricks and mortar outpatient diagnostic centers? The IT infrastructure, how are we going to move images and reports from family physicians to secondary care to radiologists and back into the system so that this thing can flow seamlessly. And then there's what's the thing that people like myself and Graham, as radiologists, what can we do to make the program worse? Well, one thing we can do is overcall benign and indeterminate nodules and put people back in the system for unnecessary 3-month follow-up scans. And we can have an unnecessarily high recall rate for incidental non-lung related findings, which can also flood the system. So we have to be very careful around those types of things. But we have written documents that we all follow. We have a national protocol for how you run a lung cancer screening program, which goes into all of this stuff. And we've written a document on how we optimally roll out lung cancer screening over the next 5 years. And Graham and I have been authors on that. So these documents are in place. Crucially, there is extensive quality assurance around readers and who can read a thoracic CT. So it is stipulated that you should be a radiologist who reads 500 thoracic CTs per year. You should have a regular attendance at a thoracic screening review meeting or multidisciplinary meeting or a lung cancer round of some sort of form. You should have attended a nodule workshop to understand screening, and you should be participating actively in local quality assurance. And through that, we can then say that your recall rates should be that, and your incidental finding recall rates should be this. And the other thing that is crucially mandated is that you must use officially nodule interval guidelines. You must do a nodule volume, not a diameter, and that there should be AI or nodule CAD detection to determine that volume embedded in your program. So we've almost mandated the use of AI to help the thoracic reader into reporting these studies. HLH, which is Heart and Lung Health or Heart and Lung Imaging Limited, is an entity set up by myself and Graham. And so I wanted to talk to you about that, because how do you get like-minded radiologists working across geographical boundaries for the betterment of patient care to try and break down some of those cultural barriers and get people working together for the greater good of improving lung cancer outcomes? And that's effectively what we've done as HLH. We are a UK-wide network of subspecialist cardiothoracic radiologists. There's now about 100 of us. We're expert thoracic radiologists who meet the standards and effectively exceed the standards. Many of our radiologists have been over to North America, to the States and Canada, and done fellowships and come back to the UK. We use a cloud-based seamless IT platform, which Graham's going to go into. We work across geographical boundaries rather than I work at this hospital and we do things this way. You work at that hospital, so I don't talk to you because you do things that way. We've broken those barriers. We do quarterly quality assurance. We go in, we train local radiologists to upskill them in reporting nodules, because in the end, doing 1.2 million scans a year, that isn't achievable with just a group of 100 thoracic radiologists. So you train and you onboard and you make people feel part of that community. You also have regular clinical catch-ups. You do real events and learning meetings. You participate in guideline updates, so you're feeding back into the program. And what you establish is a true network of expertise that fosters a real sense of community. So this is a quote from one of our radiologists: true radiology reporting community. And effectively, as we all know, networks are simply patterns of relationships. And if you build those relationships, you can build a cohort of readers who are connected on an IT platform that can deliver hundreds and hundreds of thousands of low-dose CT reports with AI embedded to help you become more efficient. The reports are pro forma template reports. So, most of our programs, so we do 80-90% of the program. We're working in partnership with an AI company called Aidence, also a RadNet subsidiary. Nicely structured reports with a clear recommendation of what needs to be done, very easy to read for the respiratory physician, for the administrative team on the ground, as well as thoracic surgeons, etc. The AI is automated. And what we've introduced, which I'm going to touch on, is a RAG rating system to triage every report. And the reason behind that is you're not just reading text. We try and triage reports for those people on the ground to make this flow of information seamless. And I'm going to touch on that shortly. I don't want to get too clinical because, as I've said, we've proven the science. This isn't about teaching people how to spot a lung cancer, but I know on this slide that there's 3 of these slides that I can dismiss and just not recall the patient because they are benign entities that are not lung cancer. But the top 3 on the left, they're lung cancer. I need to recall this patient for a scan or refer them to a thoracic surgeon. Crucially, it's up to radiologists to keep the recall rates for benign nodules low and the recall rates for incidental findings low, because if those are too high, the program gets incredibly expensive. You flood your program. This is the importance of having expert readers deliver that radiology report. Part of our community is actually, we all know, and some of you in the audience will know who are clinical, subsolid nodules. The guidance around how you follow these is completely conflicting, you know, and it depends on what you follow, and it's even completely conflicting in England. But what we've managed to do is, through the fact that we've got an expert network, we can exchange best practice on what we're doing locally for our subsolid nodules, feed that back into the national program so that the protocol always remains unified. So we have a role as expert readers in contributing back to the program and making sure the guidance is actually apt, because we're learning as we go. As we report, we feed stuff back, and the program morphs over time. This is quality assurance that we all do through our IT platform, which Graham will touch on. Each reader is benchmarked. They get their recall rates for 3-month follow-up scans, for referral to lung cancer rounds for 24-month scans. Each hospital site or region gets their recall rates and what each reader is doing in terms of recall rates. And importantly, as a chest radiologist, I can then benchmark myself against 99 or more, and it's growing, of my other colleagues to see where I fit in terms of my recall rates. This is the RAG rating I touched on. So every single report gets a red, amber, green rating. Rob touched on some of the incidental findings. Well, we've categorized those. And effectively, this is beyond just teleradiology. We've become beyond just thoracic radiologists doing reads. We have become program orchestrators, letting the admin teams on the ground know that this is a red alert lung cancer. Take that to your meeting and discuss it for resection. This is a yellow alert, there's a dilated aorta, it might need an echocardiogram performed. This is a green, the vast majority of scans, this patient can automatically get a 24-month follow-up scan. So it's centralized the position of the radiologist in terms of orchestrating the downstream effects of the screening program. In terms of our outcome data, you know, we're all using our AI. About 2 to 3% of our cases across the board, we're doing now between 13 to 15,000 scans a month. 2 to 3% of our cases we will refer for query lung cancer. And in terms of what we term actionable incidental findings, so true findings that may require action, i.e. a breast cancer, that represents around 5 to 6% of all cases. And you can see quite clearly that if you're using people experienced in screening, these numbers will remain low and not flood your program with incidental findings and benign nodules. Lastly, there's also an external QA program, and somebody touched on earlier, you know, breast cancer screening. There is an external QA platform in the UK for breast cancer screening called Performs. They have adapted that and developed a lung cancer screening external QA platform called Perfect. So each radiologist, as well as partaking in internal quality assurance, has to also participate every year in this external QA to be signed off as a competent reader for lung cancer screening. And so we're mirroring breast cancer screening in that way. However, I almost want you to forget much of what I've said, because on this journey of building it, and they will come, what we have learned is the key piece in the jigsaw isn't the science, isn't the readers, it's actually the radiology IT integrations, and they're the key to screening. How do you get a scan from a mobile van to a PAC system, to a reader, to an AI company, to a report, and then back into the system for onward management? And for that, I'm going to hand over to my friend and colleague and co-founder, Dr. Graham Robinson.
Thank you very much, Sam. Do you think you could just enable screen sharing for me now? And just while that's being just while that's being done, just to echo Sam's point. I mean, this is not about proving the science. Lung cancer screening science is proven. So the two big hurdles are obviously political, to certainly in the UK, to politically get this signed off as a national screening programme by the NHS, which has been done. And then the next challenge is essentially the architecture of how you move studies, scans, scanners around, and hopefully you'll see that we've managed to do a lot of that. So just waiting for that screen share.
Sorry, Sam. Sorry, Graham.
That's no problem.
Coming.
I've only got a few slides, so don't worry.
We're working on it here. Our apologies.
That's okay.
I think our AV guy left for a second.
If not, Sam could share. Sam could share. It wouldn't be a disaster. Sam, do you want to share? Would that
Yeah,
be easier?
I can do that, Tim. Does that
I'll just do the whole.
get you
Yeah.
out of a hole? There we
I can
go.
do the whole next slide, please. Yeah.
Okay, you're back up.
Okay. So thanks, Sam. So yeah, I'm Graham Robinson. I'm medical director at Heart Lung Imaging. So if you go to the next slide, Sam. So just to give you a bit of a picture of the UK radiology architecture, and I'm sure this to some extent mirrors yours, and yours may well be the problems may well be magnified. So we have in England about 215 NHS hospitals, and they are isolated units. There is no connectivity between them, certainly no formal connectivity, and they operate in their own as their own entity. Indeed, they all, despite us having a UK unique patient identifier, the NHS number, almost all hospitals in the UK just use their own unique identifier, their own MRM, which creates a lot of problems in linking patients up in a screening program. Over the last couple of years, the regions have been asked to try and gather themselves together. So groups of hospitals in certain UK regions are aiming to create 7 imaging networks. I was partly involved in that at an NHS level, and the truth is, that's still got quite a long way to go to be refined. And even when it is refined, I think actually the hospitals will still, to some extent, operate in their own silos. So it's this whole point of how do you join things up? And if you're trying to join the whole jigsaw piece up in England from a radiology IT perspective, we are a long way off. But that's really what you need for screening. We've also got we operate a RIS PACS architecture. So all the reporting, the booking, and the admin is done within a RIS system, and the PACS system are just for image viewing. We don't have a PACS-driven workflow. Just click, Sam. So this is where I thought we might go in the UK, that we would have the imaging networks and a national imaging registry, and that would hold all of the data. But I don't think that is going to happen anytime soon. So we're going to be left, as I say, in these silos of trying to join the jigsaw pieces up. Sam, next click. So that's where I think we are. And then if we look really at where the workforce planning is, over 90% of our hospitals in the UK are already outsourcing their routine work. So to ask them to do screening on top of that is clearly a problem. And then within the regions, about 90% of the regions also comment about sort of subspecialty skills within various regions, including lung, particularly specialist lung reporting. So therefore, absolutely, screening in the UK, I think, will be largely an outsourced model in part. So next slide, Sam. So this is how we have taken the view of a screening pathway. And the 3 grey boxes at the top are where we would say the outsource model is, and the sort of pink box towards the right is the hospital environment. So if we just take the hospital environment to begin with, what we're trying to do in a screening program is limit the downstream effect of that. We don't want to flood the hospitals with unnecessary work. So their skill will be for PET scanning, biopsies, ongoing management of the true positive cases from screening. But the outsource model, the 3 grey boxes, is where we really want to keep patients within this sort of screening loop. So we have the front end management software who work out the ever smokers, which they then get a risk score, as Sam said. That is defined then who gets the CT scan. The CT scans are performed on huge mobile fleets around the UK. They are then, the images are largely sent to us for reporting. We integrate it into the AI. And with the RAG alert Sam touched on, what we try and do is have the only things that are pointed back to the hospital that need action are the true suspected lung cancers and the true actionable incidental findings. So the negative scans are on just a loop every 2 years through screening, and the indeterminate pulmonary nodules are also managed in the outsourced model. Next scan. Next slide. Next scan. So this is the very simplified IT architecture. So the patients start their journey in primary care, and the data the primary care holder or the GP, primary physician, of anyone who's ever smoked will be ingested into the front end lung health check management software. From there, they will get the risk score, and the risk score defines which patients get a CT scan. That data is fed into the radiology information systems, which then populates the mobile CT vans as a modality work list, and it also primes the hospital PACS systems for receiving those images when they come back. Invariably, now we've tried to refine the model further, and we're learning year on year that most of the scans are now sent directly to us from the van, but some will still go through the hospital PACS system. When we get it in our PACS system, we will then send it up and down to the AI agents that Sam touched on for the nodule analysis and the volumetry. We will then report the scan with partly also with agencies via report software. So that's another integration. And then when we've reported the scan, the reports will go back threefold, so another 3 integrations, one back to the PACS system, one back to the radiology information system, and one back to the front-end management system to do that loop that I talked about. So that's principally our sort of IT architecture. Next slide. And therefore, you know, at a real IT level, these are the maps of that we've designed that we feed to the hospitals to say how the arrows need to go. There's variability within that from hospital to hospital, but what it all allows us to do is all of that can link. Then you can go from hospital 1, you can link it to hospital 2, hospital 3, then you get a region link, and you can get that region linked to another region, and we are joining those jigsaw pieces up. So next slide, please. The front end bit of the IT, which is the true, if you like, mobile bit, the scanner going around, the transfer of data from the RIS system to the scanner, is reliant on 4G and 5G. And that's where we have experienced most of the issues, you know, just on a day-to-day basis from technicalities. The bottom bit is a truly cloud-based architecture. That's our PACS, agents in the cloud, our PACS reporting. So all of our radiologists can report, and the sending back of all of the reports are also cloud-based. So next slide, please. So I don't think we would have been able to do this without a truly cloud-based platform. So we've got no software installed on any computers, be it the radiologists, our own, or those at the hospital. We've got no hardware at the hospital or on the CT van. We use a company called CMAR, which are the UK sort of European offshoot, if you like, of Ambra, which I think are well known in the States. And that has allowed us, as I say, to join those jigsaw pieces up. How we've got over that sort of single, because the critical bit to any of these IT architectures is having a single unique patient identifier. And what we've done, a lot of the sites, is that initial hospital MRN that's unique to that hospital. Within the scan metadata, there is actually the NHS number somewhere, and we've written scripts so that NHS number becomes the unique patient identifier in our system. Therefore, any patient can cross boundaries and can link up appropriately in our systems. As Sam said, we've now linked up all of the regions as shown on those green ticks in England. We're performing about 12,000 screening CTs a month currently, aiming to do, well, I mean, the projection should be straightforward for about 18,000 per month next year. And then, of course, we will go through that phased rollout, as Sam alluded to earlier in his talk. And I think we'll stop there, and happy for us to answer any questions.